This is John Marshall from Georgetown University's Lombardi Comprehensive Cancer Center, bringing to you the highlights in GI cancer from the 2016 ASCO meeting in Chicago. And I really want to focus on three main areas. I want to talk about colon cancer and the stuff that's happening there, and I'll come back to that. But I want to start with a couple of other areas. First, believe it or not, I want to start with neuroendocrine cancer. And in this study known as the NETTER-1 Phase 3 clinical trial, patients with midgut neuroendocrine cancers were treated with the lutetium-177 octreotide, if you will, the hot radiolabeled octreotide versus a dose escalation in their Sandostatin octreotide. And what we had presumed would be positive was quite positive. Now, this is a technology for treating systemic metastatic neuroendocrine cancers. It's been out there for a while and available in pockets at certain centers around the world. In fact, we would often send our patients to Europe to get it. But this positive randomized trial with a very strong progression-free and OS mark really will, I think, be the foundation for providing this kind of medicine for our patients with metastatic neuroendocrine. And we know this is an increasing disease in frequency. So if you've got some of these patients, you need to be looking out for this new therapy that I think will have a significant impact on patients' overall outcome. Switching gears slightly to pancreas cancer, and while we've been focusing over the years on new medicines that work in pancreas cancer, we had the latest of the SPAC randomized clinical trials, which actually looked in the adjuvant setting for pancreas cancer. And long we've known that both fluoropyrimidine and gemcitabine have activity in the adjuvant setting. And I'm so excited that the study was finally done where it was gemcitabine compared to gemcitabine plus capecitabine. And the study showed that the double drug doubled the progression-free and overall survival in patients with pancreas cancer. So on a dime, this clinical trial strongly supports a change in practice away from single-agent gemcitabine in the adjuvant setting to the doublet of gemcitabine plus capecitabine. So if you got patients on, switch them. And the next patient that comes in, it would be my recommendation to recommend the doublet therapy. And of course, with this new foundation, we'll be moving on from there to even newer approaches in the near future. Now, as promised, I want to focus on what happened in colorectal cancer because I know everybody's always interested there. And I think there are really two main themes that emerged around the treatment of colon cancer. First is that we are increasingly recognizing and able to characterize the different molecular subtypes of colon cancer. Today, we know we need to measure RAS. We know we need to measure microsatellite instability in everybody. We're increasingly measuring BRAF and HER2. But it's even more complicated than that. In a paper that Alan Vanuk presented, he showed that right-sided colon cancers have a significantly worse prognosis than left-sided colon cancers. We sort of knew that all along, but we've not really known what to do with it. But now we have some guidance because in his clinical trial, half the patients, and these are RAS wild-type patients, got cetuximab and the other half got bevacizumab. And the findings were that even in RAS wild-type patients who had right-sided colon cancers, their outcomes were significantly worse than if they got Bev. And likewise, on the other side, on left-sided cancers, just the opposite. RAS wild-type patients who got EGFR therapy, in this case cetuximab, did significantly better than Bev. And so it really starts to make us wonder, should we be thinking about our biologic therapy differently simply on sidedness? We already have a molecular test, the RAS, but this is now adding to that with right versus left. And we know that there is this emerging categorization of colon cancer around molecular profiling, which we're going to start to use more and more. So stay tuned for that. But do look out for your right versus left, particularly when you're selecting biologics. The last point I want to make around colon cancer has to do with the very hot topic of immune therapy. And everyone knows this is so hot, and most everybody's aware that in microsatellite unstable colon cancers, the checkpoint inhibitors have shown very positive results. And the feeling was that we weren't really seeing much benefit in patients who did not have microsatellite instability, or the majority of patients have microsatellite stable colon cancer. Well, single-agent checkpoint inhibitors didn't work in that group, but also nor did single-agent MEK inhibitors. But it turned out there's some reason to believe that a MEK inhibitor would stimulate the immune response. And so Johanna Bendel presented a paper where they combined MEK inhibitors and a checkpoint inhibitor, PD-L1 inhibitor, in metastatic refractory microsatellite stable colon cancer. And lo and behold, they showed a 17% response rate in a fairly significant number of patients with stable prolonged disease. So this says something that we were hoping would be true, that we might be able to stimulate the immune system and cut the brakes at the same time and expand the number of patients who are benefiting from immune therapy. And so this has sparked a great deal of additional research to see how broadly we can do this and how many patients in the world of colorectal cancer. So it was an exciting ASCO, some practice-changing studies in GI cancer, particularly in neuroendocrine pancreas and now colorectal. And I hope this has been useful, and thank you for your attention.